Good morning, everybody. My name is Kenneth. I'm assistant professor at Meharry Medical College. I teach in the PA program, and I have been working in technological field and the surgical field for almost 26 years, and it has become a very diverse and interesting field of study. It was primarily relegated to scientists once upon a time and physicians and aspiring healthcare providers, but now everything from engineers to computer science majors to, believe it or not, I have a son who is a theater major, and actually they even utilize folks in the arts to help develop a lot of the technologies that we utilize today. Most people are familiar with the technology that we use in medicine, particularly for imaging, so like MRIs, things of that nature. Again, with all the radiology things, ultrasounds, we have all kinds of wonderful digital formats that we use. And most people think that's primarily the major usages of technology with regard to training and understanding the human body. Um, but what we know now is that in order for students to be able to understand the technologies that they'll use once they're actually out in practice, they have to be exposed to it early. And as the years have gone by, we've seen this happen more and more and more. And I'm excited. And at the same time, for those who are on here who have studied medicine or been in medical science, you'll feel like I did when I first started seeing some of this technology emerge. I wish they had this when I was tremendous, and it really helps that transition into the next step when you're going into medical practice. Now, for me, I'm gonna see if I can pull up a couple things. I want to just take on a little bit of a historical journey, so bear with me here. I'm gonna see if I can't get this right. Make sure you guys can see. I'm gonna show you just a couple of pictures, and then I'm gonna go into a demonstration. Okay, can everybody see that okay? It's a picture of a bunch of gentlemen standing around a body. Just head nods are good. So, okay. Um, what you see here is typically the way anatomy was done back in early medical education. Probably, again, a point of emphasis. And that's pretty much who was getting educated back in the day. And now this actually is not even in the United States. Human dissection in the United States didn't occur till sometime around the 1700s. Let's see if I can get, there we go. And what you see here now is a typical dissection kit that was used to do human dissection. So you, the more that you would pick up at Lowe's or Home Depot, what you would do for human dissection or even for surgery for that matter. Of course, now we've advanced to this today. This is a typical anatomy lab in a teaching institution. You'd have several cadavers, again, these very nice tables. I can tell you they're much nicer than even what I had in school, where students are, again, they work in teams. They have a place to put their books, things of that nature. Of course, nowadays kids have iPads, things like that now, more than anything else. And we've then recently progressed to more of these digital anatomy tables. So you see like Anatomage, which that's a common type of table used. There's a couple others that are out there now. But now this eliminates the need. You can see you don't have to have all the protective equipment. If I have time, I was in school about the importance of protective equipment. But again, this eliminates that. Anybody who's ever gone to medical school or a PA school or anything like that, the other thing everybody remembers fondly is the odor that took months to get out of your skin and clothes when you were in school. So don't experience that anymore. But what technology has allowed us to do is allow us to advance, going from now just from training to what happens now once you go out into practice. And so my clinical area of practice is urology. We were one of the early users of robotic technology for performing surgery. What you see here is just sort of a demo picture of the console. So you see the surgeon sitting at the console, you see the table there, you see the robotic arms, and then you see the imaging device there. So that's actually for the, we call the circulator, and then the first assist. Over the years with robotic surgeries, that we used to talk about a second surgeon as the first assist. Or in a robotic case, we don't necessarily say that anymore, because the first assist is typically somebody who's at the table, but you'll see in later images here that sometimes we have more than one surgeon and more than one console, okay, because you need to have, if you will, four hands in there sort of too. So it's just a cartoon picture here. You see the computer console. And I would point out to you, like you saw in the last picture, and then what you see here, you notice how that console, he's looking into that, and you see how that kind of goes all the way around. The idea is that it's very immersive now. I can tell you the first generation of this was more like a really sophisticated microscope. Now it literally feels like you are inside the body, if you will, where you're performing the surgery, as well as being able to see the movements of the instruments. So you get the camera view, and it's a high-def 3D camera. So again, it's very almost, again, augmented virtual reality. You have the surgical cart that has your robotic hands, and then of course you have a circulating person, which is usually a nurse, a tech, a PA, a nurse practitioner, could be in just about anybody nowadays. Here's again of a more of a better look at what the device looks like up on the table, again, without the patient, with everybody in the room. These are very, very expensive machines. And probably the most sophisticated piece, if you will, as crazy as this may sound, if you can see my mouse, are these little things here. Those are the actual instruments. They are expensive, and even thing that might drive you even crazier, hard to believe, those are one-time use. Usually, they usually are not reused in most cases. I believe that's changed somewhat, but in most cases, those are used about one time. And so here's what I was showing you, a case of how they may have two surgeons. So you've got two surgeons sitting at two separate consoles, and they're both simultaneously operating on the patient that you see here. One person at the bed. There are oftentimes representatives from the company who may be an engineer or a computer science person whose job is basically to maintain the working parts of the device itself, as well as the photo imaging equipment as well. So very important. Very, very expensive machines. I remember a time where most countries didn't even have a machine. When I first started working in robotic surgery and in Minnesota, than most countries had. I can just tell you, just in St. Paul, Minnesota alone, I left there in 2015. And when I left there in 2015, there were 10 robots in that city, just in St. Paul alone, which is just remarkable in the entire country of Australia. So that being said, I just want to inspire you before I go into the demonstration, a little bit about the importance of having, wanting to be an innovator. Now, this is supposed to be interactive, so I guess I can ask questions. Anybody can feel free to chime in. Anybody know who this person is? I got a bunch of head nods, and nobody knows who this is. Well, this guy is very famous to me and near and dear to my heart. His name is Vivian Thomas. And he is probably what we'd call the first surgical technologist, if you will, who worked in the research lab. But what's cool about it is that this guy started out as a janitor and worked his way up and was working in the lab at Johns Hopkins, and was looking at different things in terms of animal models and things like that. He used to just clean up the lab, and then he started doing a little bit of work because he showed some skills at being able to. And I think that's the most important message I want to give you, is that he spoke up. He saw something and he said something, and then he taught himself and he learned and he worked at it. And then as he was able to demonstrate his knowledge and skill, he got to do more and more. Alfred Blaylock, and again, well-known pediatric surgeon at Johns Hopkins. who again started utilizing Vivian Thomas to help him with his development of a new procedure for they call blue baby syndrome, which was a heart procedure. Vivian was very, very instrumental, and basically not just instrumental, he really did develop the surgeon's lives. Um, um, this was later made into a movie, okay, called Something the Lord Made, okay, and it's probably one of my favorite movies. And I'll tell you why all this is near and dear to my heart. Before I was a PA, I was a surgical tech working at University of Nebraska. I did the same thing, if you will. I didn't start as a janitor, I had a degree, but I went to work there. And the job that I had was really just kind of being a lab tech, doing benchtop stuff. Then I was asked to start working at some of the animal research stuff. And later on, I actually was very fortunate to be involved in many drug trials, including FK506, which you know is tacrolimus. We were the principal on that. I was one of the lead technologists on that drug coming to market. Again, it's used worldwide now for a number of different things. I also was very interesting projects where we used animal livers, which a lot of people don't know about that. Some people do if they're in surgery, they understand, but we used animal livers, pig livers, to do what we call extracorporeal liver perfusion. And we were one of the first centers in the so I actually performed liver harvests and transplants on pigs. We used those livers from those pigs. They were lab engineered pigs, if you will, that were used as a bridge to keep humans, if you will, recipients who were crashing. We would actually hook this liver up to a dialysis machine. It would be hooked up to the patient. It would allow them to live, in many cases, a few days, and a couple of them even a few weeks longer than they would have while awaiting a transplant. And so again, I was fortunate to be a part of that, and it was a great opportunity. So again, I get this story because I kind of you lived it. Great. Not people don't recognize, this guy was a rapper too. Even his story to doing that, going into acting, I think even parallels this a little bit. It's somebody you would not think of, but he actually has since gone on to have a tremendous acting career. And again, and I always laugh. Most people don't know who Alan Rickman is, unless you're old enough. So you don't might not recognize Alan Rickman there, but I don't know anybody who doesn't recognize him there. Okay, from Harry Potter. Okay, so infamous for being Snape there. So. Now, that being said, I just want to show you one little quick video. I'm doing that really as a distraction because I have to set a couple things up to show you this, the next demonstration. So if you bear with me just for a minute, just kind of see if I can get this to pop up the right way.
Grammar and spelling are important.
All right, I'll skip that.
But if you want to write essays that inspire,
can't control that. All right. Okay, hopefully, again, that was hopefully the extent of my silly entertainment for you for this morning. So a couple of things I want to share with you. Now, one of them I'm going to tell you may be a little difficult for you to really understand the full concept of what it does, but you kind of saw the tail end of it, the augmented reality, if you will, the robotic surgery piece of that. Now we've been able to bring that to anatomy training. So we've got some 3D anatomy programs, things of that nature that we have available that we use. Second, I'm gonna start with that, and then I will go from there. There we go. So I'm going to share with you the screen again. I'm going to show you what we're doing now. Again, we've gotten away from the cadaver. And one thing that's important about when we talk about being able to do surgery in particular, or just even understanding anatomy better, be very good at dissecting, making sure that you through the dissection manuals. So you really had to be very, very careful. Oftentimes, those who recall, if things weren't going well with your dissection, then you had to go to somebody else's cadaver to learn in case in case you made a mess of things, if you will. And so now, what you can do now that's different is you can with 3D technology in particular. Now, not only can you do a dissection virtually, but you can also make sure you actually see the parts. And you can view them, you can manipulate them, you can turn them in ways that you wouldn't have been able to do back in the day. That's really important because the technology, once you're out practicing, does allow you to do that. So the earlier you is. So I'm going to share my screen with you again here. And what I'm showing you right now is 3D anatomy here. Now, this is an interesting thing. So you can see what I'm doing with the skeleton now. I can manipulate him. I can turn him sideways, flips, whatever I want to do. And I can also build him. I can add different things in to him. Let me pull this over. There we go back to my models. All right, so, but I can pull different things in. I can look at different parts of the body now that I couldn't before. And I can bring the different models in and I can add different parts to them. So if I wanted to put, again, nervous system in, I could start doing I can make him bigger. So I can look at him closer. I can make him smaller. These are all things we were never able to see and visualize back when we got a better understanding of even where relationships are. Now, I'm not being able to see all my little pieces I'm throwing. So, but now I'm just throwing. Again, this is the part here is to turn the beating heart off. So I say, got it. So now you can see the heart beating in there. Okay, in relation to that, and I can turn it. And I can see this. Why is that important to see that? Well, one of the things we teach you how to do is to listen to different parts of the heart. Okay. Again, we weren't able to do this in a cadaver, but now you can understand why you might put your stethoscope there or why you might put it there. Okay. I understand clinical medicine that we have available. So the same thing if you're performing surgery. Here, what does the heart look like if I'm coming in from there? A diaphragm or anything like that in the way. Relationship of where the different anatomical parts are, and you get a much greater understanding than we ever had again back when we were in school. So the cool thing about this particular program is this one actually travels with you, unlike the one that I'm about to show you, which requires very sophisticated computing equipment, has to have a specific type of a computer, which they've just recently taken from a all-in-one PC, which is what I'm using right now, to that's recent, and they're still working out some bugs and how they can use that. But certainly that would be great, because as an equipment footprint, it'd be much easier to have a laptop than these big machines. But this 3D program that we have here now is great, because like I said, you can study that, you can take that home. There's even a phone app version of it. So if you were out on your rotations or anything like that, and you're trying to remember your anatomy, you could go ahead and look it up. You could pull it up on your phone, look at it. Anything you save on the desktop version, other. So if you took special notes or anything like that, you'd be able to do that. So, anatomy, for without question, is the the foundation for medicine, and the ability to be able to learn this in a much more efficient and more detailed with you, literally in the palm of your hands, is a tremendous addition. So now I'm going to stop sharing here again. So if you bear with me here, I'm going to turn my video off, and I got to pull up the next thing, and hopefully this will work okay. I won't be able to see myself when I do this. So, and I'm going to be wearing special glasses. So let me tell you a little bit about the technology before I do anything. I should have made you guys just a quick link to the website, but just to give you an idea of what I can see, but you're not going to be able to see it as well. Again, under this format is the fact that not only can I see this in 3D, but I can literally pull the anatomical part that I select. I can pull it out of the screen and hover it in front of my face. So now I can turn it, I can pull it up, I can lift it down, I can twist it anywhere I want to get every that I'm looking at. Again, you would not be able to do that only in the case of an MRI or CT scan would you be able to do that, and even that isn't as detailed as this can be. So just bear with me here for a minute. I'm going to shut my video off, and then I'm going to stop sharing, and I'm going to pull up the next part here. Okay, now what you see me now is I'm wearing 3D glasses, and one thing you might notice is these little white squares that are on this. What that does, these are reflectors. So the camera that is on the machine that I'm looking at is not only am I looking at the machine, but the machine is looking at me. So when I turn my head, it turns my perspective, on the anatomical part that I'm looking at. It'll move around. So I've tried this and tested it at home already. I don't know how this is going to work across Zoom. I hope it works okay. I try to do this upstairs, downstairs thing. So hopefully we'll see how it works here with all of you. So feel free to let me know how it's going. So hang on just a second. Okay. Okay, I can kind of see, okay, flip monitor, so this is good. So can you guys see what I'm seeing? Just nod or hands up or something. Yes. Would be great. If everybody turn their videos on, that would help a little bit. Okay, got thumbs up there. Okay, fabulous. So you can see it okay. So you can see I do that. Now I'm going to go to, which I believe is the simplest thing to show you, which is the skull. Okay. Now I can turn the skull. You can see that you see my little wand there grabbing it, but you see what I can do as I turn my hand. It's very intuitive. I can turn my hand, it turns. I can look inside the skull. I can bring it closer to me. I can push it into the screen. I can pull it out of the screen. Okay. Cool thing about it too is we're doing this. Now you can learn all these anatomical parts. So I can look at the frontal bone, see if the video audio works today. It might not because I'm on the Zoom, so it may not let me do it. But so you can see, I can light up any anatomical part that I want. So the frontal bone of the skull, I can hide it. So I can just make it disappear. That'd be the same as doing dissecting. I can show it, or I can do what they call fade, which means I can see through it. Okay, which is very, very important. So if you understand relationships of other structures, like what's behind it, if you will. The other thing we can do is the software allows us to learn about what the particular part is, and we can view this part. We can also look at common conditions that are associated with this, so dislocations, fractures, things of that nature. And then bony landmarks are typically where they'd be important structures that run by, and so that's what this part would do for us. So it's very, very useful. And again, this is a perspective that we've never been able to have, at least at the level of just teaching until now. The other thing we can do now is we can add anatomical parts. So that's important. So we just have a skull here right now. So we want to put some brains in there, okay, and the nervous system, and we can do that now. And like the same thing, I can go ahead and get rid of that frontal bone. And now I can see the next structure, which actually is the covering of the brain, the dura mater. And so I can look at that. And same thing, I can keep dissecting down. I can hide that. And if you will, then I like to do this. A lot of times I like to turn. I can remove another part of the skull as I'm trying to learn. So the parietal bone, I would get rid of that. And again, I would just manipulate it in such a way so I could see it. And now I could literally look at each individual sulcus if I wish, and remove them. So I can get rid of the frontal lobe. Okay. And then we look at the midbrain, and we can remove that if you will. We go down here, look at the cerebellum. So same thing, again, lots of ability to go in and look at where representative structures are. And the same thing, if I need to know about the blood supply, I can throw that in there now, and I can take a look at that, and then really get an understanding of where that blood supply goes and where it actually, how it transport blood to these different parts of the brain. Again, this is a visualization we never had when we were in school. And I can honestly say even the imaging, I'm old enough to tell you the imaging wasn't even this fantastic like we have here. And mind you, this is just an atlas, and this is just one program that I could show you. There are others that actually do the anatomic drawings like this one that can convert it into a cadaver, then who can convert it into a radiology image. So I could see it as an MRI or a CT scan as well. So again, this is the way we can do this stuff now that we were not able to do in the past. So, and I'll just show you one other quick thing here that I think is important. So looking at each individual body part, so this part, because I'm looking at the skull and the head and neck, if someone wanted to know exactly which muscles are responsible for moving, which muscles are responsible for opening again or closing the jaw, closing your mouth. You can actually see it working. And I still do the same thing I showed you before. So I can move this just like I did before. I can highlight muscle it is. Now, the only thing I don't get to do with this is I don't get to hide or fade or anything like that, like I did when it's in the video mode, but even that's okay. Because I still get the idea on what I need to see for this particular, again, demonstration here. And with that, I'm going to stop my share, and then I am all done. I'll be happy to answer any questions anybody might have. I don't even have my watch on. I don't even know if I went over or not. Hopefully I did not.
You have not, Mr. Mitchell. We are actually ahead of time. If we could go ahead and move forward with our lived.
I'm sorry, can you hear me now?
if we could go ahead and move forward with our lived experience from Dr. Boyd, we will take our Q&A at the end of the session.
Yeah, sorry guys, I've lost audio.
Dr. Boyd?
Sure. Good morning, everyone. My name is Dr. Boyd. I hope that everyone is doing well and in good health.
I'm sorry guys, I lost audio. This happened to me again. It's showing that it's working, but I'm not hearing anything. Hold on.
I'll continue. I'm sorry. I was invited more so to give you insight into my role as a primary care provider, as a nurse practitioner, but also into my journey getting to this place. So I'll start off with my journey. I grew up in South Memphis, and for most people that are not familiar with the city, I'll give you a little bit of background. Currently, about 45% of children live under the poverty line, and most schools in my zip code that I grew up in, 38106, they score below proficient. I grew up in a two-parent household where my mom and dad did everything they could for my younger brother and I to have food on the table, clothes on our backs, and Christmas presents under the tree. The focus of my parents, though, were to obtain a decent education. So with that being said, we commuted to school every morning, 30 to 45 minutes. And I say this to start off because I don't want future students or future practitioners to know that your circumstances or situations, whether past, present, or future, it shouldn't be a roadblock for your goals or aspirations. I remember being introduced to science and engineering as a child, probably about first grade. The program was an after-school program called SCMS. And I remember being excited and loving science and falling in love with science because I could make Legos move as a robot. I've always had an affinity to being in healthcare. I remember as a child, my parents bought me a doctor's set, which included a plastic stethoscope, a white coat, and a black bag. And I remember lining up my stuffed animals every Saturday morning to have clinic. When I knew that I wanted to get into healthcare, I think was later on in what capacity, but initially I was invested in it early. I remember my younger brother during his delivery being at the sink in the waiting room, washing my hands, pretending to scrub up to help with delivery. And the nurses played along. They gave me a gown to use to wear so my clothes wouldn't get dirty. I can say that education coupled with right time, right place moments, mixed with opportunities is what got me to this point in my career. As my bio states, I'm a graduate of Lamona College biology major. And I absolutely love my HBCU because this is where my foundation for self and career was built. Initially, my idea of going to college was attending class and staying out of trouble. So to avoid trouble, I would go to my dorm to sleep. I ended up becoming a proud member of the Get Your Rest committee. But I'm glad that there were individuals placed in my life, such as Dr. Painter, I don't know if she's on or not, that mentored me into a different direction. Dr. Painter was one of the first professors that introduced me to research. Research was something that I initially had no interest in, more so because it was extra work and it interrupted my sleep. But my love quickly grew and I traveled to conferences like this to present. And before I knew it, I was published in scientific journals. That experience alone built my confidence to jump into unknown territory. I didn't feel afraid to fail because at this point I felt like I could take any challenge head on. if there's one takeaway point from this throughout the whole conversation, it would be to more so just take hold of opportunities, because they can push you out of your comfort zone and force you into things that you may not have imagined experience. So I fast forward, I'm in my senior year of Lemoyne, knowing that I want to work in healthcare, but in what capacity, I'm still uncertain. Dr. Painter again introduces me to a program hosted by the University of Tennessee Health Science Center to more so focus on MCAT prep, which is the entrance exam for medical school. So I enroll, I complete the program, I take the MCAT, and then I score unsatisfactory for admission into med school. I believe that at that moment, it was a time for me to be self-aware and really assess myself and my goals. I knew that I didn't want to stop school or stop attending school for a year to retake this exam. I knew that if I stopped going, that this Get Your Rest committee members would come back and find me. I more so didn't want to fall into those complacent habits that I had formed. So I knew I had to continue the momentum, and I didn't want to be comfortable with doing nothing again. A few months prior to graduation, I sat in on a seminar during Career Week, and I met other grads who attended the nursing programs at UT. And after speaking with them, I was more so inspired to enroll. And I would tell anyone that nursing school, PA school, is a very challenging curriculum. But I felt like because I didn't allow myself to lose momentum and motivation, I could get through it. So I completed my master's in nursing. After my master's, I started working in correctional nursing as I re-enrolled directly into my doctoral program at UT again. My role as an MP now comes full circle, and that I serve the community from which I came. And I feel like I'm impacting the lives of patients at their most blissful moments, but also in their dark and most vulnerable moments. My job in healthcare as a primary care doctor or provider is to more so see you as a patient holistically, meaning I don't just see you as a disease, I see you as a person with an ailment. And my goal is to see if I can assist in any way, physically or mentally, to help you get through this together. And what I'll do is I'll more so end with saying that comfort and growth do not go hand in hand. You must place yourself in uncomfortable positions and situations and test your mental strength and endurance to develop you to the next level of you. And with that, I am done. Thank you so much for listening. If you have any questions, please shoot them. We'll try to answer them as best as we can.
Dr. Boyd, thank you so much for that lived experience. It seems as though you came from the bottom and now you're here. Next, we're going to move on to our oral presentation with Ms. Tremaya. Is it Lauderdale?
Yes, it's Lauderdale.
Ms. Tremaya.
Hello, my name is Tremaya Lauderdale. I am a senior at Lane College. Can you hear me?
Yes.
I'm a senior biology major at Lane College, and I'll be giving a oral presentation about our CRISP project of our HIV-1 protease. And basically, well, let me give you a background on what HIV is. Human immune deficiency virus affects 37 million people worldwide, and it causes acquired immune deficiency syndrome or AIDS. And basically, what HIV does is impair the immune functions in the human body, and usually you contract it through bodily fluids. And HIV attacks your body's immune system, specifically your CD4 T cells, And your T cells help your immune system fight off infections, and HIV hinders that. And basically, we have a 3D model. It's a homodimer, and basically a homodimer it shows two polypeptide chains. So we have one side is the lavender color and the other side is pink. And when with this model, we're able to take it apart so we can show the inhibitor and the UMass and the Dondervor. I'm skipping over. We have the Antiviral Therapy Arc, and basically it's a mix of the UMass 6, I think. It shows the UMass 1 and UMass 6 in Dondervor. And when I take the top piece off the protein, in the yellow, you can see the valine right here, and the valine connects with the inhibitor in this part. So in the middle part, we have the valine, we have the isoleucine. They're in the gray, and the valine is in the yellow. I don't know if you can really see it or not. And basically the medicine causes a mutation, and it helps fight off drug resistance. And it also helps with the van der Waals inhibitor structure, because this is the inhibitor. And when I take this part off, you can see the residues on the inside. And another thing about our model is that it had another part that was supposed to be shown here. I forgot what it was. And you can actually push the inhibitor part out because it's missing the one piece that's supposed to keep it together, one of the molecules. And another thing is that the 150 valine mutant, it changes the entire structure. That's what I was just talking about. I'm playing with it. And it changes it changes the attraction with the van der Waals interaction between the active site and the inhibitor in this mutation. And I think that's overall what I have to say about it. And this is our HIV protease 1.
Thank you again, Tremaya, for your lovely presentation. I hope you shook off all of those jitters. We are now going to open it back up for our Q&A portion, led by our facilitator, Mr. Kenneth Mitchell. If you have any questions at this time, you can come off mute and have your camera shown. Turn your video on, raise your hand, and Mr. Mitchell will start calling on people, engaging people.
Thank you. Again, if anybody has any questions for any of us, it would be great. Okay, Ms. Robinson. So many people and everything's so small.
I have a question for I have a question for Ms. Boyd. I know you practice in primary care. I'm very interested to know what is your favorite part, or what do you love most about primary care?
So primary care is a little different from specialists in that we are more so considered the gatekeepers of healthcare. What I mean by that is we're your first stop in the healthcare realm. We help people navigate from there. So for instance, you come in and you have a symptom, we try our best to investigate it at that point. If we need further assistance, we send you to a specialist, whether it's a heart doctor, ear, nose, throat. or for a procedure using the equipment that Mr. Mitchell showed. That is something that I do not do, and I'm not well versed in that at all, but Mr. Mitchell has enlightened me at this moment. But I send patients to have those type of procedures. But ideally, we are your first stop in healthcare. And from there, we help you to navigate the system because it can be complex. And we try to be your resource. So for instance, you can always come back to us, ask questions, call, and we try to be available. Did that answer your question? Okay, all right.
Very good. Anyone else? I had a couple of nice little comments again. So it sounds like several people saw that movie. So like I said, if you haven't seen it, highly recommend it. I can't believe that movie's 16 years old, but it is. But it's a tremendous, tremendous film. Still relevant today, I think. So, we're too early for everybody. Well, I'll give a shout out to Prime and internal medicine, and then I flipped over to surgery. So, you know, believe it or not, I will say that it never leaves you. The primary care is it never does. So, I got a question over here, Miss Oliphant.
Yeah, hi, good morning. I'm from Breakout College in Augusta. I'm in, I think this is my senior year. I got a few more classes. And what I'm going into is physician assistant. And I want to know, I know it's very challenging trying to go into physician assistant. Well, are there research programs that I can go in during the summer when I'm not in classes that I can participate in to help me with going on to my program as physician assistant?
So, what they find attractive in candidates to go into school. So there are some that prefer that you do some shadowing with a PA, that you have a real clear understanding of what it means to be a PA. That helps. You know, that's outside of the GPA requirements that they have. Many schools had GRE requirement. Not everybody's doing that anymore. Now there's talk of an MCAT-like exam for PAs, and some people are okay. None of those things are predictive of how well you'll do. So we're kind of, I could tell you we're not huge fans of that stuff. Most people, particularly, I always say this about primary care folks, PAs, nurse practitioners generally, if hairstylists and bartenders and things like that, there's some intent, you will, that are successful, that are now really being focused on by many programs around the country. So it's important, obviously, that you have a good academic chops, if you will, so you're able to successfully complete the program. But some of those other things that really allow you to deliver healthcare, not just know it, but deliver it, are the things that they really are starting to look at. So I highly recommend things like that. If you can shadow, some folks, do some volunteer work where you'll have a lot of exposure, that always looks good on an application. So
Another question. Mm-hmm. When would you suggest that I start shadowing?
As soon as you have time, before you apply, so you can put it in your application. That's what you did. Okay. So, okay. Yeah. So.
Okay. Thank you.
Mm-hmm. Anyone else? It must be too early for everybody. I won't even tell you what time I wake up. So I got a couple cameras coming on.
Yeah, I have a question. Can you hear me?
Yep, there you go, Mr. Boss.
Yes. So when it comes to technology and this augmented reality use for A&P, obviously in the clinical sense, there's a lot of money involved with that and implementing that. How long do you think it's going to be before we start seeing that taught at the or used in the undergrad level to train our future students to be accustomed to this technology?
I will tell you, it's happening now. Z-Space, so the thing I showed you, the 3D of me just kind of manipulating things around like that. Like I said, you can't appreciate Z-Space unless you're in front of it and you're actually getting to do it. You couldn't see me pulling that skull out of the screen and hovering it in front of my face. You couldn't see that. They started with Z-Space actually at the elementary school level. So if you get on zspace.com, if you just get on their website, you'll see them teaching basic science stuff to elementary kids. That's the video they show. They're teaching them, butterfly anatomy and how they work, and it has everything from chemistry to engineering. I mean, you name it. I mean, they teach auto mechanics with it, home building. So it's already happening. That particular company is really pushing hard for there to be more STEM usage of Z-Space at that level. Now, the challenge, the grant money that's available for a lot of elementary school districts, things like that, to get that stuff is probably easier to get than it is when you get to the higher education level. So I always said my biggest fear was that if students were exposed to something like that at that level and you didn't have something as good or better by the time they got to college, they're gonna be like, I don't want to go to there, Xbox to a pinball machine fun for the students. So, but yeah, that's a great question actually. But yeah, happening now.
Thank you.
Any other questions?
Well, I guess I have another question for Dr. Boyd. My question is, did you set out to become a primary care physician when you were in med school or prior to that, or did your expectations change as you were pursuing that career?
So I'm a practitioner, yes, but no, more so than anything, I think clinicals and experience kind of shaped my view of where I wanted to land. Initially starting out, I felt like I would love to be with kids and work with them, but clinicals showed me otherwise, that I felt like the best place for me to be at that point would be in primary care. I love to educate patients, sit with them, let them understand the disease process, so that they could make better choices and go forward. So ultimately, I believe that the clinical experience is what guided me to this area in primary care.
Well, thanks. Kind of following up to that, how much is technology aiding you in your connection with patients? For example, do you bring an iPad and show like their test results or whatever? And is there anything else that's letting you connect more and educating the patients more?
So what I realized more so sitting through the conference today, because I do take it for granted how well technology helps me communicate with the patients and not necessarily being aware of it, because we use it from day in and day out. One being, in each of the patient's rooms, we have what we call a display board, and on this board we're able to more so show patients a 3D version of the anatomy of the body, pinpoint exactly where we anticipate the ailment to be, where they're going for surgery. We show them disease process, and it has movies and projections to be able to better explain to patients visually what to expect. We also have patient portals, and with that, you can shoot us a message. We try to get back to you within 24 hours of that message to communicate. If you have a question about anything, we send labs. And now, because of COVID, we're integrating into telehealth, where we see patients directly from their homes. in the comforts of their own homes. And ideally, that's been a joy to incorporate into practice at this point.
Does the volume of patients that you see through telehealth, has that dramatically increased? Or is it just a different avenue for them to see you and just kind of the same volume?
So ideally, we weren't necessarily a practice that incorporated telehealth. Most of our visits were physical and face-to-face. We did some version of telehealth where if you call and you say, hey, I'm just not feeling well, we'll call you back. But at that point, we weren't necessarily integrating a visual concept into that. COVID changed things. It made us adjust and adapt to a different situation. And because of that, yes, the volume of patients via telehealth increased initially, but I'm feeling like people are becoming a little more comfortable with their precautions and such with COVID. And so because of that, they're starting to visit us in office a little bit more. We're shifting back into our old dynamics. We still do telehealth, is still offered for patients, especially if they have comorbid conditions or are of the elderly population that makes them more susceptible to COVID. We still explore that avenue with them, but some of them just love coming to see us. And as of that, they knock down the door and they're like, listen, I'm coming in. So we make accommodations for them, but it's been interesting just exploring that avenue, but it's all in relation to because of COVID.
All right, thanks.
That's a good. I'd add comment to that. So in the surgical subspecialty world, I kind of look at telehealth like we knew it was coming. It just got shoved forward. I mean, at a rapid pace. Specialty. Even though we deal with a lot of cancer, probably the biggest thing that we do in urology. A lot of those follow-ups ended up having to be via telehealth. But what was nice about that was it also helped us kind of realize, maybe this could have always been done that way for some of it. And, all of a sudden now for those people that do need to come in, it kind of freed up space a little bit, for those physical visits. So it's not a bad thing. A pandemic is a bad thing, but what we learned out of it is been good. So as I say, necessity is the mother of invention. I mean, it really shown us what it could be, and I think it's going to drive what we do in the future. I got a really good question in the chat actually, and I'm actually glad somebody asked a question. So the question was, and should I as a patient feel reassured that my procedure will go well using this technology? So no, it's not as precise as the human element, and nor is a cadaver for that matter. So I tell the people all the time, I said, cadavers don't bleed, hearts aren't pumping. So it looks nothing like what you would see. Best advice, best example I could give you is to hold a pancreas in a living person in your hands. The best way I could tell you, it's like holding very watery jello. But in a cadaver, it feels like a Nerf ball. I mean, you would think that, oh, well, that must be what it's like. So it's neither was going to be. But if you have a better eye for the anatomy, and again, being able to get those windows, as we call it, those looks at anatomy through a small window that you used to not be able to do. So you couldn't appreciate a 1-inch incision over the femoral artery and what that looked like. Well, now you can. Now you can literally with the technology, we could show somebody, if I'm making a 1-inch cut here and I go down into that hole, what am I going to see? It tells me exactly what I'm going to see before I go in there and see it. And that hasn't changed. So it doesn't replace anything. Technology is just, if you will, an improvement over what we used to do, but it never ever took the place of the real thing. The trick though is whether you're learning anatomy on a cadaver or you're doing it via technology, the importance is that you understand the roadmap before you get in there, and that's high end of the technology now. they can do these augmented reality 3D pictures of. I've never been involved. I've seen some of that stuff. It's just amazing how, you know, you could look at steps on how to perform a surgery, but now where you can literally see a 3-dimensional video of what it would look like before you go in and do it. That is just, you know, mind blowing to think about that now. So, but great question. Paid internship opportunities recommended students can explore. I, for one, don't know of any, although, Dr. Boyd, you can also comment on this, but I know one of the things they really, now that's not technically an internship, and also to really be exposed to clinical medicine. That's a huge thing to do. Now there's a lot of students that are applying to medical school, PA school, MP programs that are working as scribes for a while. So they're getting that exposure to patient care, and also exposed to diseases and illnesses and what's it like to have a conversation with a patient about their condition, or even how to discover what's going on with them. I mean, you can learn a lot from just being in the room taking notes. I mean, clearly. And to get paid to do it makes all the sense in the world to me. Great opportunity to do that. So, so I don't know, do you have any comments about that?
Ideally, I don't right off top know of any paid internships, but one thing that I realized talking to other nursing students now, especially when they're interested from Lemoyne to go into nursing program, is that a lot of times they start nursing without necessarily knowing exactly what it entails. And then they absolutely either love it or hate it. So one thing is to just make sure you get your feet wet, get into network, get into communities where you know nursing or other subspecialties to be, shadow, do opportunities like that. So at least you know if you like it or not, because we don't necessarily want you to go through all the process of admissions and things like that for you to absolutely hate the process.
I agree with that 100%. Know what you're getting into. About you, but I personally, my mother was a nurse. She was a surgery nurse. So I've been around it my entire life, you know, and you'd have thought I'd gone the other direction, but so, but no, as you can, you know.
I have a question.
Sure.
Hey, okay, so as a surgeon, were there any failures and how did you keep yourself level-headed?
Failures? Oh, there's always failures. I'd love to tell you that, you know, now you make me say something. This is an opinion thing. I know this is being recorded, so it's an opinion thing. You know, you're supposed to get 100% on your test. You're not gonna get 100% in life and practice. It's not gonna happen. There are things that are gonna be out of your control. And so, so again, I'm going to tell you what my mom told me when I graduated from school, because she was very smart about that. She said, there'll be highs and there'll be lows. She goes, don't think too highly of yourself on the days when they're highs, and don't think so badly of yourself on the lows. You know, that was critical, if not vital advice that I received. That is what keeps you level. I mean, it really is. You know, it is great to have, you know, under your belt that I saved a life today, but understanding that that's not always going to be the case, and no matter how hard you try, it's just going to be out of your control. You know, that helps you keep straight. There are some, when I worked in transplant, you know, the good news for me was I wasn't the physician and I wasn't a clinician then. So I was a research guy, you know, so these were, you know, for me, more often than not, they were names and numbers, you know, but, you know, the stories around that, you know, knowing that, you know, transplant being the kind of both ends of the spectrum, somebody had to die for somebody to live. That's a crazy thing to think about, you know. So before the days of transplants having donor teams at the hospitals. One of our jobs was we had to go on the donor runs, we called them. So if a donor was available in Florida, we would have to fly to Florida, retrieve the liver, bring it back to Nebraska. Where I was at research tech and went to school. That's where we had to go do that, you know. Sounds glamorous, but it is in the world, you know, to go there knowing that somebody's losing a loved one, but when we leave, it's over. But it's crazy to go back. So when I arrive back where I came from, somebody's gonna live. So it's yeah. So that in and of itself just tells you the situation. So. See if I have any more other questions in the chat. Nope, I don't. I apologize. I'm terrible. I didn't put a watch on. How are we doing for time? We okay?
Yes, we have about 20 more minutes.
Okay. I can share with you that one thing I was going to share with you too, if you about the protective equipment. So back in the day when you had to wear all that. This is a true crazy story. So those who are in clinical medicine that are on will get this, or those who've had undergone what I'm about to talk about will know. So I told you I was a research person. So I was on call for the transplant service while I was at PA school. I did work in there. A lot of our tissue work involved using radioactive isotopes. So I had to wear a radiation badge. Just basically that would measure, you know, how much radiation I was exposed to. So I had my radiation badge, and so because I had an office, even though I was hardly ever in it, I would use my own white coat that I had from being employed to go work in the anatomy lab, and I had my own scrubs I'd steal from the surgery locker room. So I had, you know, I kind of was lucky. I was going to school where I worked. So I went over and was working on my cadaver. It was great. Did, you know, was doing like everybody else was trying to do. And I went in for my monthly scan of my badge, and my scan showed that I had an elevation in a radiation exposure. And I said, well, okay, you know, who knows what that was from? I didn't think much of it. It was a high, but it wasn't crazy. I went back in another month later. There was a significant spike in the amount of radiation I was exposed to. And I said, well, that doesn't make sense, because I said, I haven't been in the lab working on any isotopes or anything like that, or working with any. And so they said, well, where have you been? And I said, well, I've been in class, or I've been in the anatomy lab, or I said, you know, where do you know? So they said, well, maybe we need to go. And they literally, the radiation safety, and they had to scan where I was at to see what was going on. Lo and behold, they got to the anatomy lab, and there was a spike in radiation in the lab. And it wasn't horrible, but it was enough when you walk in the room, they could detect it. But as I got closer to my body, it got really hot. And it turns out that the person that we're working on, and we hadn't done head and neck yet, had radiation, had pellets put in their thyroid. And so they were still hot. And so, you know, nobody, to my knowledge, and I still keep in touch with everybody who was at that table. I can tell you, nobody's had cancer or anything like that. But that was one of the things that happened with me. And if I hadn't had that badge, we probably never would have known. We'd have gone the whole semester and done that probably. So it was crazy. So, but anyway. Let's see. This went to everyone. So got another question for Dr. Boyd. Can you describe some of the primary factors that are assessed when providing care to a patient? Is race one of these factors in living conditions?
So sure, good question. We always take into consideration, or at least the practice does, those factors: ethnicity, living conditions, because they all play a role in disease progression or risk of a disease, a certain specific disease. We know African Americans, higher risk of high blood pressure, diabetes, things of that nature. Family history plays a role in that. So of course, and so one prime example, a diabetic, discussing things with them. One thing that we came across was more so dietary measures, of course, to try to control diabetes. And it wasn't until later that we learned that the patient was homeless. So diet won't necessarily be such an appropriate topic with that patient, even though it's important, but we have to more so compromise in that area because we can't tell the patient, well, go to the store and buy fresh fruits and vegetables, things like that. It has to be a little more of a compromise in that area because they can't necessarily afford factors that we know play into their disease progression. So yes, things like race, things like social economic status, living situations, all play a role in our treatment plans of patients. One of the questions when you first come in as a patient of ours is, are you single, married, divorced? What's your education level? Things like that. Because if I'm talking above your head with things, I won't necessarily be able to meet you where you are as a patient. And that's one of the prime things that we have to more so focus on is meeting you where you are so that we can assist in any way possible with eliminating or either controlling disease progression. You're welcome.
Here we go. Anybody have any questions at all?
I was like, I'm trying my best not to ask all the questions.
That's okay.
Come on, I know we have some students out there who have some questions. And I guess as a mother, I have so many questions about primary care and, you know, doctors, the body's makeup and things like that, especially, I guess, lungs and things like that, how they work, and the coronavirus, how it affected our lungs and our respiratory issues. Mr. Mitchell, have you been doing any research or studies on COVID-19 and its effects on the body?
Wow. Surprised you asked me that question.
Oh, I'm sorry.
No, it's fun. No, well, a week from today, I'm giving a talk about that very thing. And I'll give you the very much the Cliff Notes version on this. So I recently was asked a question. So I do work in urology, and I have and my clinical specialty area, subspecialty in that is men's health, actually. And so the question I was asked was, why is it affecting men and why is it affecting African-American men more than anyone else? And as it turns out, I'm gonna go back to what Dr. Boyd said, really start talking about diabetes, hypertension, anybody who has what we call metabolic disease actually is more at risk than anybody else now. We thought it would be respiratory people, but they're really not the ones who are getting sick and dying like we thought. And there's a very clear explanation. People who have metabolic disease express more of we call ACE2 receptors on their cells, in particular in the nasal passages, and with regard to COVID-19. And I always tell people, think of ACE revolving door, but it never stops. It's always open. And the more doors you really at risk. And when you men out there with metabolic syndrome and women have metabolic syndrome, so that's why we see greater levels of infection there than we do anywhere else. So I was actually find it really interesting because even it made me think more about like, why weren't we seeing more of the respiratory autoimmune people? Well, it appears, makes sense now that we understand this, what happens with this virus. A lot of them are on anti-inflammatory medications. And so even if they get sick, they don't get as sick as somebody who would if they weren't. So, and that's, what we've learned. And so it's interesting going back, questions about basic research and information, things like that. My undergraduate degree is in molecular biology. It seems like no matter what I do, it goes back to that. I don't care what we see. I don't care if it's hypertension. I don't care if it's prostate disease. We're always back to those cells again. It's always about them. But yeah, that's a great question. I'm gonna go Miss Oliphant, you had a question? Nope, we can't.
Yes,
There
I'm
you go.
sorry, y'all. It's this to Miss Board, Dr. Board. Like I said, I'm at Payne, and I'm in my senior year, and I got like 4 or 5 more classes, and then I'm going on for a PA. The thing where I've been an LP in like 35 years.
Awesome.
But now I'm not working at all because my senior year is very challenging for me. And right now I'm really trying to find some research stuff so I can start doing some research this summer, because next year I'll be finished. Well, next fall probably, because I'm not taking as many classes I normally would take. But the thing about it, when I find someone to reach, is there any other program that can work with us while we're in school that can head us on to PA school?
I'm not so much more familiar with the PA tract than I am nursing.
Yeah.
But as far as programs are concerned, it'll be more so networking with local individuals that are already in their career path. I would say to get with them and see if they have any guidance, or if they can even network with you individually one-on-one and be a mentor at some token to be able to answer those type. I don't have a program or an internship off the top of my head. I'm sorry.
Okay, well, where would you suggest that I start at?
And a lot of individuals will start at their own doctor's office. I've had patients of mine who want to venture out into nursing school, or who want to further their education in the field of healthcare. And they ask me to be a mentor for them, or even at some token clinical guidance. So I would say if you don't necessarily have a network, meaning more so family members and things like that are already in the healthcare field, that you can go to your primary care provider and say, look, I'm interested in doing X, Y, and Z. Is there any way you can help?
Okay, great idea.
Yes,
Thank you.
My first supervising doc was my personal family physician. Just so you know, I mean, he literally asked me to come work there when he was seeing me when I was sick. And I was like a semester in, I'm like, I'm just trying to get through. I don't know about where I'm going to work, but yeah, so that's a great suggestion. Let's see, I guess we've got about 10 minutes or so left. Let's see if we have any other questions at all.
I have a question for Dr. Boyd. First, I would like to, can you hear me?
Yes, I can hear you.
Okay. First, I would like to applaud you for your amazing testimony. And I have a question about, what's the most rewarding aspect for being a nurse practitioner?
I feel like in time and time again, you will find that there are just a handful of patients that you see at their worst, and you see them through whatever disease progression may be, and you see them out on the other side. A lot of times in primary care, I not only deal with physical ailments, but also a lot of mental health. We're like one-stop shop for mental health. And so dabbling into that, a patient comes in with a crisis, they don't know what to do, maybe talks of suicide. Ideally, helping and ushering them and nurturing them through whatever situation they may be in has been the most rewarding thing. Seeing people become the best them that they can be has been the most rewarding. It has its challenges. There are some days where, of course, I'm frustrated. I don't know what to do, things like that. But otherwise, the rewards at the end, I feel like are far more rewarding per se. It definitely keeps me motivated and driven in that regard. You're welcome.
I have a question for Dr. Boyd.
Yes, ma'am.
Okay, what's the difference or between the PA and the nurse practitioner? Which one do you prefer? I don't know. Is they about the same I don't know. What's the difference between both of them? You would say.
And I'll ask for the help of Mr. Mitchell in this regard, but I feel like it's more so just the entry point in which we penetrate the healthcare system. We all have a foundation to more so treat patients. But ideally, it could be from a route of a nurse. It could be from a route of a PA or an MD, a medical doctor. But we just took different tracks to get to that point. Now, depending on which state you're talking, there's some legal ramifications around practice and what the scope is of each field and all that good stuff. But ideally, to simplify it, it's more so we just penetrate the healthcare system differently.
I'm from Georgia, but the school amount is still different too, isn't it? As a nurse practitioner and a PA.
I'm sure there is some differences in financial situations or regarding the curriculum. Yes.
Dr. Mitch, could you answer that question for me?
Yeah. So the way it's described is that the PA training is what they call a medical model. Right. So it follows much like medical school. I mean, we often joke that it's medical school with your hair on fire. But nurse practitioner, again, most nurses who've gone in it, usually most of them have been practicing as a nurse for a while. With a lot of experience already, patient exposure and the like. But then they have, depending on what they decide to do. So nurse practitioners can go into nurse anesthesia, they can go into family nurse practitioner, they can go into midwifery if they want to deliver babies. So they have very specific tracks for that kind of stuff. PAs is really designed surgery, and it's a standardized curriculum nationwide. If you will, in the curriculum, like there can be in NP programs. And that's, again, because it just depends on what that NP program focuses on, is what decides that. There's no advantage or disadvantage of one over the other, to be honest with you. I'm friends and close friends and colleagues with many NPs. We've worked together, collaborated. In fact, most of my writing projects have been done has just been me and an NP. I probably collaborated more with NP and research projects. But that's really about the difference. But at the end of the day, like she said, you'll find us all filling similar roles when it's all said and done. So, and then, like she said, now it's a political legal issue, right? In terms of who gets paid more and how they get paid. And, I know about, Dr. Boyd, I stay out of that stuff, to be honest with you. I've made it this far. I'm hoping to retire without having to touch any.
Agree.
Yeah, where we're used. Yeah, that's the biggest thing. Where we're used. That's a big thing. Yeah. Yes, Ms. Robinson.
I have a question for you. So I've had the opportunity to see that anatomy program in person, and it is amazing, like you talked about. But I was wondering if you had any suggestions for what we might be able to use at home. Maybe not as great as that, but a lot of us are interested in, brushing up on anatomy. So.
Yeah, so that first program that I showed you, that Complete Anatomy, you can purchase that one. I don't think it's horribly expensive either. I want to say it's like $99. And the phone app might be, I don't know, $4 or $5 like that. So the companion app. So yeah, so it's not horribly expensive. I mean, so, but that's called Complete Anatomy. If you have PC, and then on, you should be able to look that up on iTunes. And if it's PC, the Microsoft Store, you should be able to find it, download it. Like if you've got 5 computers, you can put it on all 5 computers. It's a cloud-based program. So, yeah. All right. Well, I guess we're about done. I got my warning shot. So, saying that we had about a minute to go. So I would like to thank Dr. Boyd and one Joshua group involved, actually. I think it's great. Like I said, I'm sad that I can't have everybody sitting at a station and playing. That job is easy. I talk about it for like a few minutes and everybody just plays, and it's kind of like serving dinner. Everybody's quiet working and I just sort of stand around and don't do anything. But it's a tremendous opportunity. So, and then Tremaya as well. Thank you. That's a big step for you. That was awesome. Good job on presenting again for us molecular biology geeks. I appreciated that a lot. That was nice. Again, thank you all for attending, and I hope the rest of the conference goes really well for all of you. And I hope that we were able to help inspire you to move forward and move on in your education and again, make an impact on the world. So thank you again.
Thank you, Mr. Mitchell, Dr. Boyd, and Ms. Lauderdale. We are about to transition back into the main room, our main general session room, where we will hear a presentation from Mr. Clark entitled, I do apologize. Of course, I lost my notes. Oh, your career choice will require grit. That's by Mr. Nathan Clark, a managing partner of Chasm Architecture LLC. And then we will transition to our second set of breakouts. So this is your time that you can go grab some water or do whatever necessary to prepare for that next session.